And we are going to move on to another controversial topic. We're going to move on to chest pain right now. We're going to hear 3 different lectures, and they're actually going to be from our current All NYC fellows. We're going to talk about a do-nothing approach versus getting a stress test versus doing a CCTA for low-risk chest pain patients. This is a little more of our bread and butter in emergency medicine. So we're going to start off with a do-nothing approach for low-risk chest pain, and this is going to be from Dr. Grossman. He is the education chief at Maimonides Medical Center. He is our All NYC fellow, and I'm excited to hear your talk. Thank you.
Thank you so much. Hey everyone, I'm Duncan. I'm one of the All NYC fellows, and I am super stoked to kick off the topic of low-risk chest pain, but not just low-risk chest pain, but what to do with low-risk chest pain. So I want you to imagine you're in your emergency room and your attending turns to you and says, I want you to go see this patient. Get up off your chair, you walk over, and this is not unlike 100, 1,000 other patients that you've seen before. I want to introduce you to Miss D. Super nice lady. She's 52 years old. She has a couple comorbidities. She's got some hypertension. She's got some hypolipidemia. And she's coming in and she's complaining to you of stabbing chest pain. And it's not a super concerning story. So it is on the left side. It comes and goes, but it's not exertional. It's sort of spontaneous. You know, every couple minutes it comes on, it goes away. She doesn't have any nausea or vomiting. She's not sweating. She's not complaining of any shortness of breath. So she's going to get an EKG. She's going to get a troponin. She's going to get a chest x-ray. And then what? What are you going to do with this patient? So before I try to convince everyone here to just send Miss D home, we all need to be on the same page and agree when we're talking about low-risk chest pain, what we mean by low risk. So if people start quoting like Timmy and Grace to you, it's like sort of old school. The emergency medicine community has really settled on the heart score at this point. And I know everyone knows this. Just to recap, keep us all on the same page, you get different points for different parts of the heart score, right? So H addresses your history, E addresses your EKG. You get further risk stratified based on your age and your number of risk factors. And then finally, last, certainly not least, your troponin level. So you take all of these points in the score and you add them up. And if you get 3 or less, you're considered low risk, which means you have a 1.7% chance of badness. We need to qualify this a little bit further. So 1.7% chance of something called MACE. This is a very famous number and a very famous metric. So this is major adverse cardiac events. And so this is what we're looking for when we're deciding if the patient can go home or not. So some of these things are what you would expect, right? So a major adverse cardiac event is having a heart attack or is dying, but it also includes a couple of provider-driven interventions that I would call into question. So one of them is getting a CABG and another is getting PCI. So that means if you came into the emergency room complaining of chest pain, and 29 days later, your cardiologist caths you and puts a stent in your coronary artery, you've had an adverse cardiac event. And so I wonder if there's another metric we could use, something maybe more clinically relevant when we're trying to stratify these patients. We could even call it CRACE. You could call it clinically relevant adverse cardiac events that we're searching for. These would include things like STEMI that needs to go to the cath lab. Death, I think, also should be on there. And how about, forgetting the provider-based interventions, how about any sort of cardiac or respiratory arrest or any sort of fatal life-threatening arrhythmia? Well, lucky for us, a group of researchers came together and looked at exactly this question. This was a few years ago, and they published this study. It's called The Risk for Clinically Relevant Adverse Cardiac Events in Patients with Chest Pain Who Were Admitted to the Hospital. So not even low-risk chest pain. This is all patients with chest pain admitted to the hospital, and they were looking at CRACE. It was done over 5 years at 3 emergency departments, and they looked at all of the adults who were admitted with chest pain, and they said, okay, of all of these adults admitted with chest pain, let's gather up all the ones who never made troponin, 2 negative troponins. And they had 11,000 of these patients. And I just want you to think in your head what percentage of people you think ended up having STEMI, death, arrest, or arrhythmia. So 0.18%, an order of magnitude less than our MACE number that we're always searching after. And this group went even a step further. So they said, okay, 20 out of 11,000, pretty good. what about the people that we would have sent home from the emergency department? What about people who not only didn't make troponin, but had normal vitals and a normal EKG? So believe it or not, still 7,000 of these patients were admitted to the hospital, which is like mind-boggling to me. And just imagine in your head how many of these 7,000 patients with normal vitals, a normal EKG, and 2 negative troponins, how many of them had CRACE? There were so few of them that they were actually able to talk about each individual patient in the study and why they died. Okay, I can hear your judgments through the Zoom. I get it, you guys are like, Duncan, I'm not gonna change my entire practice pattern based on one study you like kind of glanced over while I was half asleep on Zoom and half Amazon shopping. First of all, that's rude. Second of all, I get it. That's fair. This is not, the ultimate, the penultimate study. There are issues with it. It's retrospective. It's a chart review, and it was for really short-term outcomes. But I think this argument successfully makes successfully makes the argument that admitting patients like this doesn't reduce the chances of them having bad things happen to them. But I think what you can come back at me and say is, Duncan, you spent the first several minutes of this presentation talking about the heart score and MACE. Isn't that what I should be looking for? That is the standard of care. So if my patient has a 1.7% chance of MACE, I want to lessen that. I want to, send them to the observation unit for stress or further imaging to prevent them having an MI. And I was on board with you, but unfortunately, that's just not true. We're not lessening MACE like that. So for those of you like me who thought more testing was going to prevent MACE, in the same year, in the same journal, a group came together and they published this study with a very long title, which basically says, we're going to compare people in the emergency department with chest pain who had additional testing and who didn't have testing and just went home. And we're going to see how many of them had an MI within 190 days, so 6 months. Huge numbers here. 420,000 people, and they looked back at all of their charts, anyone who was diagnosed with chest pain, and they ended up splitting them into 2 groups. So this group on the left had further testing. They had stress test, they had coronary CTA, and they had perfusion studies. And this group on the right, diddly, they didn't have anything, and they compared their rate of MI. So this was the rate of MI if you had further testing from the emergency department. And this was the rate of MI if you didn't have further testing. So there's no difference. We're not preventing MIs within 6 months. But what we are doing is that group on the left, a lot of the different subgroups in there ended up having further additional testing within that time frame, which is not benign, right? Costs more for the trips to the hospital, hanging out around COVID patients. So I hope this was helpful, brief but helpful. If you're going to consider 2 points from this presentation, I just want to give you these 2 things to dwell on. So first, is MACE a flawed measurement? Are we focused on provider-driven interventions for these patients when really we should be looking at the clinically relevant adverse cardiac events for these patients? What exactly are we hunting for? And the second thing I would ask you to ponder is, based on that second enormous study, is consider the position that more testing doesn't lead to fewer MIs, but it does lead to further testing. So if you're sending your low-risk patient to the observation unit, just ask yourself, what's your goal for that patient? And that really brings us back to Miss D. 52, a couple of comorbidities, kind of not super concerning story. So what are we going to do with Miss D? So this is how her ED course plays out. Her vital signs are normal. You do an exam, it's fine. She gets 2 negative troponins and her EKG is normal. And I would say unequivocally, you can send Miss D home. I'm not saying she shouldn't follow up with her cardiologist, but I am saying that we shouldn't be sending this patient from the department for more testing. But Joe and Francie are going to pose a couple of alternative pathways for Miss D. So Joe's going to talk about stress test for Miss D, and Francie's going to tell you about how CTA could be beneficial for this patient. Thank you guys very much.
Awesome. That was really great, Dr. Grossman. Thank you. So we are going to listen to Dr. Offenbacher's approach. He's going to be covering stress tests for low-risk chest pain. He is senior resident at Jacobi Montefiore Emergency Medicine Residency and one of our all-NYC fellows. So take it off, Joseph.
So good morning, everybody, and thank you, Duncan. My name is Joe. And today I'm going to speak with you a little bit about the role of EKG stress testing and the evaluation of low-risk chest pain in the emergency department. So I have three main goals for this morning. The first is to suggest that the one test or one diagnostic approach fits all mentality is not necessarily the best paradigm when considering low-risk chest pain in the ED. The second is to try and convince you that the clinical question you as the physician are asking actually matters, and specifically that the question as to the patient's coronary status is a meaningful question to ask in the ED. And third, that EKG stress testing is a safe and effective way to look at the question mentioned above. So, when considering any question in medicine, it's important to start with the clinical fundamentals. Ischemia to the heart can manifest in a wide clinical spectrum, with a major tipping point that we will discuss. ACS can range from being completely painless to experiencing pain at predictable intervals, let's say at 1 o'clock on a Sunday afternoon, to the classic clinical presentation of I have acute onset left-sided chest pain radiating to the arm with nausea, vomiting, and diaphoresis. Importantly, this clinical spectrum actually reflects variables in underlying pathophysiology of the diseased coronary artery, from progressive luminal narrowing with intermittent subendocardial ischemia, secondary to developing atherosclerosis, and culminating in complete luminal occlusion and full myocardial ischemia, secondary to plaque rupture. With such a broad underlying pathophysiologic process, it makes sense that answering these questions would need, or at least benefit from, different diagnostic modalities. If you are asking, did my patient, did Ms. D, suffer from acute coronary vascular catastrophe, such as an MI, this might be answered on the one end of the spectrum by a rule out of two troponins, or ruled in with emergent intervention and evaluation. In contrast, worsening ischemia secondary to progressing luminal compromise might be better evaluated with other modalities, and then may warrant other approaches to intervention and management. So in discussing low-risk chest pain, we could make the argument that we're not simply looking to rule out a STEMI or other cardiovascular catastrophe, but looking for clinical manifestations of underlying atherosclerosis is meaningful in the ED context. In effect, asking the question, is our patient's coronary physiology suitable to maintain adequate oxygen supply if we increase demand and stress on their heart? If our patient's underlying coronary physiology cannot supply adequate perfusion with increased myocardial work and demand, then we may have uncovered a very significant disease process that may warrant further intervention and subsequent management. So with this underlying scientific understanding, a bit of history is also important. Roughly a century and a half ago, electrophysiology is born. Within a few decades, normal and abnormal electrophysiological patterns are recognized to reflect underlying cardiovascular disease processes. Ultimately, we learn that under stress, cardiac function can be assessed by a variety of different modalities, and that these findings can serve as reasonable diagnostic surrogates for indirectly assessing our patient's underlying cardiovascular status. So shifting gears very slightly to their literature, the question of the evaluation of low-risk chest pain in the ED has fascinated the ED physicians for the better part of 2 decades. Approaches have evolved with the advent of new diagnostic modalities and tools, but at the core, management strategies have always been centered around exercise stress testing, which has been shown to be safe and effective for considering the patient's underlying coronary health. So the first major study was done in 1993 by Kearns, which was a prospective non-randomized study looking at very narrow inclusion criteria, specifically looking at low-risk chest pain. Their initial findings of patients with negative treadmill stress tests showed that at the 6 months follow-up, none had evidence of coronary artery disease, none had had a major MI, and none had experienced sudden cardiac death. They were able to conclude, therefore, that the exam itself was safe, efficient, cost-effective, and practical. They ultimately surmised that cardiac stress testing is a useful aid for clinical decision-making and may help to prevent unnecessary hospital admissions. By 1998, Kirk and Amsterdam followed this up with another much larger prospective study, 212 patients. Their findings showed that 125 of these patients had a normal treadmill stress test. None of those patients that experienced the stress test had an adverse effect, and that at the 30-day follow-up, there were no adverse cardiac events in the negative group. They again concluded that this test was safe and highly utile. And in 2002, Amsterdam and Kirk again looked at one of the largest cohorts of these patients, looking at low risk chest pain in the ED. They looked at 1,000 patients. 64% of these patients had negative stress tests, and 13% of these patients had positive stress tests. At the 30-day follow-up, in the negative stress test group, only one patient had had a non-Q wave MI, whereas in the positive group, 4 patients had had a non-Q wave MI, and 7 had required revascularization. They therefore concluded that the immediate exercise stress testing of patients who presented to the ED with chest pain and evidence of low clinical risk was safe and accurate for determining those who would require admission and those who could be discharged for further outpatient evaluation. So by way of an analogy, in football, as in medicine, the specific question you are asking is what matters the most. How many games will my team need to play in order to assess if they have a chance of winning the Super Bowl? Well, that all depends on the specific team you are asking about. For some teams, it only takes 2 games into the regular season to know that they have no chances of making it to the Super Bowl. You can basically two-trope those teams out. On the other hand, some teams will really need to go through the stress of an entire season before anybody can draw any meaningful conclusions. So let's just say that I managed to convince you that the one approach is better than another paradigm is not necessarily the best way to look at the question of low-risk chest pain in the ED. That I was able to convince you that there is value in assessing the coronary vascular status of even low-risk chest pain patients in your ED, and that EKG stress testing is a safe and reasonably effective clinical modality for addressing this question. Always remember that there is no such thing as reverting to the automatic pilot of clinical algorithms or prescribed patient workups. No matter how many studies declare a test safe, consider the underlying EKG morphology at the background of all of the slides that have been shown. If you send a patient with this easily could be seeming benign EKG for an exercise stress test, let's just say that it may not remain a very benign stress test for very long. So in summary, when evaluating low-risk chest pain in the ED, clinicians must thoughtfully combine a thorough history and clinical exam with appropriate diagnostic adjuncts chosen to answer the specific question that you are looking for at the time. Thanks so much.
Thank you, Joseph, for that perspective. We're going to move on to our last talk of this EBM kind of discussion. We're going to be discussing the utility of CCTA for low-risk chest pain. I'd like to introduce Dr. Rusnak. She is the Education Chief at Mount Sinai Morningside West, and she's going to be leading off this discussion. Thank you, Dr. Rusnak. We'll just have you unmute, and then I think you're good to go.
Okay, perfect. So hello, everyone. I'm Frances, one of the All NYC Fellows, third-year resident at Mount Sinai Morningside West, proud resident there. For this next part, I'm discussing coronary CTA for the evaluation of low-risk chest pain, and I'm going to be using that same definition of low risk that Duncan described earlier. So we may not all be familiar with coronary CTA and its place in the workup of chest pain, so I'm going to take some time and go over some basics. It's also known as CCTA and uses at least a 64-slice CT imaging to provide an anatomical evaluation of coronary artery stenosis. The negative predictive value of coronary CTA is 100%, as determined by a 2009 study called Rule Out Myocardial Infarction using computer-assisted tomography. So CCTA is often used in the workup of patients with low and intermediate risk of coronary artery disease, which is usually determined by things like the heart score. But a lot of the studies that I've done in research for this talk really group low and intermediate risk patients together. So there are a few nuances that go into the logistics of ordering and performing a coronary CTA for your patients. Where I work, this is done sort of outside the ED, so you can't get it in the ED scanner there. Patients have to travel out to a different floor and get it in the radiology department. And it's also only available certain times of the day and certain times of the week. So in order to get adequate images, patients' heart rates must be below 70. To achieve this, they're given beta blockers, either oral or IV. And if those are contraindicated, then possibly calcium channel blockers. Sublingual nitro is also sometimes given to help better visualize the arteries. Their vitals then have to be monitored throughout, and a radiologist who has subspecialty training in cardiovascular imaging will interpret the study. The most important question to ask yourself is this even available in my emergency department? Can it be ordered and done through the OBS unit, or is this something more inpatient, or do I just have to completely refer out for it? Of course, this imaging is contraindicated or avoided in pregnant patients, those with contrast allergies, severe AKI or CKD where you have some concerns. It's also contraindicated in patients who can't receive those beta blockers, for example, active asthma, maybe a borderline blood pressure. Patients cannot have a persistent tachycardia, and they cannot exceed the maximum weight of a CAT scanner, of course. Then there are certain times where coronary CTA is not the most appropriate test since we have other ways of working up chest pain. Consider alternate testing if patients have concerns about their additional radiation exposure. Elderly patients, say those over 80 or so, who may have extensive calcification artifact that's going to limit evaluation of stenosis. So then you might want to proceed down another route. And then you also have patients who have known moderate or severe coronary artery disease. These patients won't benefit from CCTA imaging and instead should probably just move on to a cath. So when you get the report, CCTA is going to provide you with a percentage luminal diameter narrowing of the left coronary artery, right coronary artery, LAD, circumflex, and their first order branches. So if you get a report of normal coronary arteries, that's great. These patients can be safely discharged from the emergency department. But you may have a report of mild, less than 50% stenosis, moderate 50 to 69, or severe, greater than 70% stenosis. Those with mild disease can still be safely discharged from the emergency department, and you can consider starting them on preventative therapies. Moderate disease will require functional testing to determine if that's causing a perfusion deficit, and they may need a cath. And severe disease, cardiology consult, and cath. So over the last 10 years, there have been some great studies done, and they've identified some wonderful benefits of coronary CTA. It has been shown to decrease the time to diagnosis in the emergency department, the time to discharge in the ED, and the overall cost of care in the ED. All this is going to make your boss happy. In addition, coronary CTA can provide information on plaque characteristics that can help to identify some high-risk lesions. Coronary CTA imaging may also identify alternate diagnoses for a patient's chest pain. So things like a PE, dissection, effusions, pneumonias, malignancies can sometimes be picked up. And importantly, a 2018 randomized controlled trial that came out of Scotland followed patients for 5 years and showed that those who underwent coronary CTA versus standard of care, usually with stress testing, were more likely to be started on preventative medications. So things like aspirin, statins, antiplatelets, and lifestyle modification. This study showed that the coronary CTA route was associated with a lower rate of coronary heart disease and non-fatal MI versus standard of care, which is thought to be due to the earlier identification of coronary artery disease and the initiation of these preventative medications. Another great point is that coronary CTA has been shown to provide this idea of a MACE-free period. MACE here again, cardiac death and non-fatal MI. A 2011 follow-up study to that 2009 study I first mentioned showed that normal coronary artery imaging provided a 2-year MACE-free warranty period. And we also have data from a 10-year follow-up study. Here, patients with normal coronary CTA results had an annual event rate of 0.04%, which translated to an event-free survival period of 10 years against cardiac death and non-fatal MI. But of course, some downsides have been identified. Those who go down a coronary CTA pathway end up with greater overall radiation exposure. And some studies show an increase in the rate of downstream testing and the rate of invasive coronary angiography. And there's also concerns that it increases your overall cost, not just the cost in the emergency department going down. But there are some caveats. Newer studies show that while downstream testing and invasive coronary angiography increase in the first few months as compared to standard of care with stress testing, these rates end up being similar at the 5-year mark. And important to mention that those who have a coronary CTA and then proceed to cath end up having more disease on those caths versus those who have caths after stress testing. And even some new studies show that overall cost of care may not be as significant as previously thought. Another downside to those who undergo coronary CTA is that they are still coming to the emergency department for evaluation of their chest pain. And while coronary CTA finds the stenosis, it's always unclear if these are clinically relevant stenoses causing ischemia. To determine this, patients will then require a functional test, since coronary CTA shows anatomy only. But again, this last point may be changing. What you're going to see next for coronary CTA is a functional component to the imaging called fractional flow reserve. This is a calculation that looks at flow before and after the stenosis to help determine its clinical significance. And as always, we have some current guidelines that can help to inform our practice. So the NICE guidelines are coming out of England. They're evidence-based recommendations that state that coronary CTA is the first choice diagnostic test for typical and atypical angina or those with STT changes or Q waves on their EKGs. But what we're probably all more familiar with is the 2018 ACEP clinical policy. These provide a level B recommendation to not order further diagnostic testing, including coronary CTA or stress test, prior to discharge in low-risk patients in whom MI has been ruled out to reduce 30-day MACE. Instead, what you can do is arrange follow-up in 1 to 2 weeks for them. But if that's not available, you can consider further testing prior to discharge or observation. So let's go back to our case. We all know that Mrs. D is low risk. She's 52, hypertension, hyperlipidemia, atypical chest pain with a negative workup in the emergency department. So in the heart score, she has a 0.9 to 1.7% risk of adverse cardiac event. Is coronary CTA appropriate for her? Well, I'm a PGY3 and a resident like most of you, and this is really a controversial question. I lean towards ordering a coronary CTA for her because there is this sense of diagnostic certainty it can provide. And also there's the fact that I may be able to reassure her that she has normal coronary arteries, she is low risk, and she has a MACE-free period. Not to mention, I may be able to find an alternate cause of her chest pain. So taking that all together, it's really appealing to me. Whether it truly reduces overall mortality, I think is still to be determined. So in that low-risk chest patient who you think will benefit from some of that reassurance, or in someone where we want to start the workup, for example, someone who is not yet hooked into the system or you know is going to have a difficult time following up, I think this is a good test. So of course, it's an individual consideration, and it's going to depend on the time of day and the coronary CTA capabilities of my workplace. But I will be incorporating this into my future practice. So big thank you to Dr. Holly Thompson and Dr. Bonnie Brown for helping me with this presentation.
Thank you, Dr. Rusnak. That was a great presentation. We are now going to move on to the panel discussion where the three of you can kind of fight this out. I'm also going to introduce Dr. Kaushal Shah. He's actually the vice president of our All NYC EM committee. He's also the vice chair of education at Weill Cornell Emergency Medicine Department. Dr. Shah, I'm going to have you take away this discussion.
Sounds good. Thanks, Frasso. So I am super impressed with all of your presentations. I really want to commend you guys. This is probably one of the most important topics in emergency medicine. We deal with this every day. We've talked about central lines, we've talked about intubations, but really low risk chest pain and chest pain in general is a daily question for us. So I really want to start with, and we don't have a lot of time, so for people in the audience, if you have a question, throw it in there now. Everything's been about the Jets and the Giants so far, so feel free to ask something about chest pain. But the thing I want to ask, and we're going to make this quick, is now that we have Miss D in your ED, and I'm going to go with Francie thinking I'm at the right time of day, I'm going to get a CT coronary on her. Joe and Duncan, now that you've heard all the arguments, where do you guys stand? And I need a quick answer because then I have a follow-up question.
My quick answer is I'm not going to send Miss D for a coronary CTA. I've got COVID. I've got Candida auris in my emergency department. She's already been there for like 7 hours probably anyway. I appreciate what Francie was saying about the 5-year MACE period, which is nice, but I'm pretty confident that her risk of MACE in 6 months is also super low. So as long as I can get her follow-up within 6 months, I'm super happy sending her home.
Okay, that's a 10-year warranty, I think is what Francie said, if there's no calcium there. So that's pretty good. All right, Joe.
Yeah, I think I would hedge a little bit. I mean, I think on the one hand, understanding her underlying coronary physiology and anatomy, I think is important. She's 52. There is a chance there's something there. I think ultimately, because we don't know how many of these underlying plaques will ultimately rupture, so it's two different processes. It's hard to decide whether or not that will give us any long-term prognostic value. I think it probably does have some value in the long run, and it depends on if it's something that's easily obtainable. If it's something that's easily obtainable, I think it probably would be worthwhile in a patient like this.
Yeah, so, I really want to touch on this idea that we've already brought up, but I think it's worth emphasizing that when patients, especially low-risk patients, when they come to the hospital, they're not looking for MI or no MI, right? Most of them will tell you, I don't think I'm having a heart attack. I had chest pain last night. I just want you to tell me what's wrong with me. And so that's when you get into the question of, do you tell them that you don't have acute coronary syndrome, which you shouldn't, because you can't tell that from, a troponin or two. And so, what if they're not low risk? What if they're just above that and they're moderate risk? What are you guys going to do? So Francie, I'm going to start with you, since you talked about the coronary CT. Where do you stand?
I think that you can certainly use a coronary CTA for them. There's going to be some caveats, and it's going to be sort of patient specific, but you may be surprised and get a negative coronary CTA, or you may be able to recategorize people into that moderate, from moderate to mild, depending on what they have. But you'd have to see what sort of prior testing they've had. If they've already had a coronary CTA, something like that, then it's time to move on.
Francie, before we move on, there's a question for the panel, which is, can you speak a little bit about, you did talk about the radiation exposure, but what about false positives in the coronary CT group? And then they end up with more testing and then a cath, which they didn't need. Can you talk a little bit about how often that happens?
I don't have a specific number on how often it happens, but it certainly happens less than stress testing.
All right, sounds good. All right, Joe and Duncan, thoughts on a non-low risk chest pain, and would you do any follow-up testing?
I feel like this is that classic wastebasket answer of shared decision making. I think it depends. I think some people come in and they're not going to be low risk no matter what. They're like 1,000 years old and are daily smokers and have 19 comorbidities, and their EKG is always messed up, and they have CKD, so there's always a little bit of a troponin. I think probably the standard of practice is if that person comes in complaining of chest pain, they're probably going to stay the night, whether that's inpatient or in an observation unit. But I don't know, that Weinstock paper with the paper that was showing 2 negative troponins, if they do have negative troponins, even moderate risk. I think if I had a conversation with the patient's cardiologist and they were like, oh, I can see him in the office tomorrow, it's fine. And if they wanted to go home, maybe this will ruffle some feathers, but yeah, I think it could be okay to send home a non-low risk chest pain.
Yeah, I mean, I think there is a value to evaluating these people over time. I think we often underestimate that there is a value to time and giving a little bit of lag, especially for patients that might be functionally compromised. So these patients, I think it's worth admitting and observing over time, whether or not that means you immediately go for some kind of more invasive testing, or you're just observing their progress over time. I think that's probably valuable, especially if they're intermediate to higher risk.
So, okay, just to summarize, because we have 1 minute left, the message I think I'm getting from all of you is that the low-risk chest pain people probably and almost certainly don't need further workup in the ED, but you're not opposed to having them follow up and again, being a patient advocate, doing shared decision-making, plugging them into the system, because these people are not zero risk for some kind of coronary disease, but they're not having an issue at the moment. And so as emergency physicians, we can advocate, but we definitely don't need to increase cost, increase testing by admitting those folks. We didn't get into observation units, but I see Frossel's already on, who's going to cut us off. Thank you guys. You guys did a fantastic job.
Thank you.
Thank you, everyone. Didn't mean to cut you guys off. That was a really great discussion. And honestly, those lectures were amazing. You've really set the bar really high for resident lecturers and for attending lecturers. So thank you for those talks, everyone.